Hello, welcome back to this channel. Today the topic of our video is another group of important antibiotic, that is tetracyclines. Tetracycline is basically produced by the Streptomyces genus of a bacteria, Acinetobacter. Tetracyclines are basically broad spectrum antibiotics that are bacteriostatic, and the mechanism of action of tetracycline is inhibition of protein synthesis by acting on 30S ribosomal subunit that we will discuss later in this video. Tetracyclines are basically water soluble and slightly bitter in taste. They are available as hydrochlorides that are more soluble, while aqueous solutions are unstable. Tetracyclines that are available for clinical uses include tetracycline, oxytetracycline, demiclocycline, doxycycline, minocycline, and a new synthetic subclass, that is glycyl cyclines, has been added that include tigecycline, that is a semi-synthetic derivative of minocycline. So this table shows the classification of tetracyclines that is based on the basis of duration of action of drug. First is short acting, that include tetracycline, choletetracycline and oxytetracycline. Half-life of this short acting group is 6 to 8 hours. Intermediate acting, whose half-life is 12 hours. They include demiclocycline, methacycline, and long-acting include doxycycline, minocycline, and tigecycline. Half-life of these long-acting is 16 to 18 hours. Tetracyclines enter the microorganisms either by passive diffusion or by energy-dependent process of active transport. Then tetracycline binds reversibly to 30S subunit of bacterial ribosome, and when the tetracycline drug is bound to 30S subunit of ribosome, it will inhibit the binding of amino acyl transfer RNA to the acceptor site on messenger RNA ribosome complex. When there would no binding of amino acyl transfer RNA on mRNA ribosome complex, then it would not add any amino acid to the growing peptide, and it would block the formation of polysomes, that is a complex of transfer RNA and messenger RNA that would lead to translation and protein synthesis. So this figure shows the mechanism of action of various antibiotics that act by inhibiting protein synthesis by acting on ribosome. This is the structure of ribosome. This is the 30S small subunit, and this is 50S larger subunit that contain this transfer RNA that would bound to this messenger RNA and ribosome complex, and then it would add the growing peptides including amino acids and would undergo protein synthesis. So tetracycline acts by binding on this 30S ribosomal subunit, thereby preventing the binding of this transfer RNA on this messenger RNA ribosome complex. When there would be no binding of transfer RNA on this complex, there would be no addition of amino acids on polypeptide chain, and would no protein synthesis would occur. Antimicrobial activity of tetracycline. Basically all gram-positive and negative cocci were originally sensitive to this group of antibiotic, but now Strep pyogenes, Staph aureus and Enterococcus respond. Strep pneumoniae sensitivity has decreased. Neisseria species are active against many of tetracyclines, especially minocycline, while in case of gram-positive bacilli, Clostridia species and other anaerobic bacteria respond to this group of antibiotic, but mycobacteria do not respond to tetracycline except Mycobacteria leprae respond to only minocycline. While talking about gram-negative bacilli, an important gram-negative group of gram-negative bacilli, that is Enterobacteriaceae, are largely resistant to tetracyclines, while Vibrio cholera, Yersinia, Campylobacter, Helicobacter, and Brucella respond to tetracycline. Some H. influenza have also become insensitive to tetracycline. Important gram-negative bacilli that do not respond to tetracycline include Pseudomonas, Proteus, Klebsiella, Salmonella, and Bacteroides. Spirochetes including Treponema pallidum and Borrelia are quite sensitive to tetracyclines. Similarly, Rickettsia species and Chlamydia are also highly sensitive to tetracyclines. Mycoplasma and actinomyces are also moderately sensitive. Protozoa like ant amoeba histolytica and Plasmodia are sensitive to tetracycline only at high concentrations. Various mechanisms of resistance have been developed to this group of antibiotic. Three important mechanisms include: first is impaired influx of drug or increased efflux of drug by an active transport protein pump, that include TET efflux pump that would be formed in many gram-negative species, and in this case when there would be increased efflux of drug out of the cell, then all the tetracycline would become resistant. Only tigecycline, that is not a substrate of these pumps, would be susceptible, while when the TET efflux pump would be formed by Staphylococci bacteria, only tetracycline would be resistant, while doxycycline, minocycline, tigecycline that are not the substrate of this pump would be susceptible. Second mechanism of resistance include ribosomal protection by production of proteins that interfere with the binding of this drug to the ribosome. When there would be no binding of tetracycline to ribosome, then this tetracycline would not be able to perform its function of inhibition of protein synthesis of bacteria. There are some proteins that are TET-M ribosomal protection proteins that are expressed by many gram-positive bacteria that inhibit the binding of tetracycline to ribosomes. And in this case, tetracycline, doxycycline, and minocycline would become resistant, while tigecycline, due to its bulky substitute, would be susceptible. Third mechanism of resistance is enzymatic inactivation, that would be chromosomal mediated, and they would be undergone by Proteus species and Pseudomonas aeruginosa that would have intrinsic resistance to all these tetracyclines. Pharmacokinetics of tetracycline include absorption. Absorption after oral administration of drug is 30% would be absorbed chlortetracycline if taken orally, 60 to 70% for tetracycline, oxytetracycline, demiclocycline, and methacycline, while 95 to 100% of doxycycline and minocycline would be absorbed if taken orally, while tigecycline is poorly absorbed orally, so it should be administered intravenously. Absorption mainly occurs in upper small intestine, and absorption would be impaired in case of food except doxycycline and minocycline, multivalent cations, dairy products and antacids, and alkaline pH. So after absorption, next step in pharmacokinetics is distribution. Tetracyclines are basically 40 to 80% bound by serum proteins. Tetracycline hydrochloride or oxytetracycline oral dosage of 500 mg every 6 hours would produce peak blood levels, while in case of doxycycline or minocycline, 200 mg dose would produce peak blood levels. So last step in pharmacokinetics is excretion. Tetracyclines are basically excreted in bile and urine, mostly by glomerular filtration. Important point in tetracycline is that they cross the placenta and can reach the fetus, and they are also excreted in breast milk. And important point is they undergo chelation with calcium, due to which they damage growing bones and teeth. Doxycycline and tigecycline, in contrast to tetracyclines, are eliminated by non-renal mechanisms. Tetracyclines are excellent for the treatment of Mycoplasma pneumonia, chlamydia, and spirochetes, as we have discussed earlier. Spirochetes and chlamydia are quite sensitive to tetracycline, and also for gastric and duodenal ulcer caused by H. pylori and Vibrio cholera infection, and chlamydial infection including STDs. Gonococcal diseases respond to doxycycline when used in combination with ceftriaxone, and treatment and prophylaxis of protozoal infections, for example Plasmodium falciparum. Other clinical uses of tetracyclines include treatment of acne, Lyme disease, some non-tuberculous mycobacterial infections, for example Mycobacterium marinum, exacerbation of bronchitis, relapsing fever, bacterial gastroenteritis and UTIs, community-acquired pneumonia, and leptospirosis. Tetracycline is the only and drug of choice in case of rickettsia diseases, including Rocky Mountain spotted fever, typhus, rickettsial pox, and Q fever, while these are used in combination with other antibiotics in case of plague, tularemia, and brucellosis. Minocycline can eradicate the meningococcal carrier state, but it is not used because of its side effects and resistance. The dose is 200 mg oral daily for 5 days. Demiclocycline inhibits the action of antidiuretic hormone in renal tubules, so it is used in the treatment of inappropriate secretion of antidiuretic hormone. Tigecycline is the first glycyl cycline that is a semi-synthetic form of minocycline, and many bacterial strains that are resistant to other tetracycline respond to this group of drug, and it is very broad spectrum, including coagulase negative staphylococci, MRSA, and vancomycin intermediate staphylococcus aureus, and vancomycin resistant strains also respond to this tigecycline. Penicillin susceptible and penicillin resistant streptococci also respond to tigecycline. Enterococci, including VRE strains, also respond. Gram-positive rods, Enterobacteriaceae, MDR strains of Acinetobacter species, anaerobes, Rickettsia, Chlamydia species, Legionella pneumophila, and rapidly growing mycobacteria, they are all susceptible to tigecycline. While Proteus species and Pseudomonas aeruginosa are intrinsically resistant to tigecycline, tigecycline is only available for IV administration, and dose is 100 mg loading dose and then 50 mg every 12 hourly. Volume of distribution is quite large, and tigecycline is eliminated primarily by biliary excretion, and no dose adjustment is needed in case of renal insufficiency. So the major adverse effect of tigecycline is nausea and occasionally vomiting. Basically, tigecycline is used in the treatment of skin and skin structure infections, intra-abdominal infections, and community-acquired pneumonia. Oral dosage for tetracyclines. For rapidly excreted tetracycline, the dosage for adults is 0.25 to 0.5 gram 4 times daily, and for children it is 20 to 40 mg per kg per day. In case of severe systemic infections, higher doses indicated for demiclocycline or methacycline. The daily dose is 600 mg, while for doxycycline 100 mg once or twice daily. For minocycline it is 100 mg twice daily. For oral administration, the tetracycline of choice is doxycycline because it can be given twice daily and its absorption is not affected by food. In case of tetracycline, they chelate with metals and they should not be orally given with food, milk, antacids, and ferrous sulfate. And they should be avoided in pregnant females and children younger than 8 years to avoid deposition in growing bones and teeth. Parenteral dosage. They are only available for intravenous injection. Intramuscular injection is not indicated because of pain and inflammation at the injection site. So the dose for intravenous injection is 0.1 to 0.5 gram every 6 to 12 hours, and the usual preferred agent is doxycycline at a dose of 100 mg every 12 to 24 hours. So the adverse effects of tetracyclines are basically due to direct toxicity of drug or the alteration of microbial flora. They do not undergo hypersensitivity reactions. Gastrointestinal adverse effects of tetracyclines include nausea, vomiting, and diarrhea, and they can be controlled by administering the drug with food or carboxymethylcellulose, reducing the drug dosage, or by continuing the drug. Tetracyclines basically alter the normal gastrointestinal microflora, and they would lead to intestinal functional disruption, anal pruritus, vaginal or oral candidiasis, and important infection that they would cause is Clostridium difficile associated colitis. So an important adverse effect of tetracycline is their effect on bones and teeth. They are, as we have discussed earlier, they undergo chelation and they are readily bound to calcium that is deposited in newly formed bones and teeth. So when they are given to pregnant females, they are deposited to fetal teeth, and they lead to fluorescence, discoloration, and enamel dysplasia in fetus. And when they are deposited in bone, they would cause deformity or growth inhibition. And because of these side effects, they are usually avoided in pregnancy and children younger than 8 years of age. Other toxicities include impair hepatic functions, especially in case of pregnancy, hepatic necrosis, renal tubular acidosis, and nephrotoxicity. Venous thrombosis can also occur in case of IV administration, while painful or local irritation and inflammation can occur in case of intramuscular administration, and they can also induce a sensitivity to sunlight or photosensitivity in especially in fair-skinned persons when they would be administered systemically, especially in case of demiclocycline. while the specific side effects of doxycycline include dizziness, vertigo, nausea, and vomiting. So this was all about tetracycline. Thank you for watching this video. Stay tuned and subscribe to this channel for watching more informative videos like this.